All right, it looks like it is 12:30, so we will go ahead and get started. I just want to welcome everyone and thank you for joining us today. Please feel free, if you haven't done so already, to introduce yourselves in the chat. Just be sure to select everyone from that drop-down list there. So we are Maryland Behavioral Health Integration and Pediatric Primary Care, short for, or long for BHIPP, Maryland BHIPP. So we are a child psychiatry access program that supports the capacity of primary care clinicians throughout the state in treating and managing child and adolescent behavioral health concerns. And then as one of our newer services that some might not be familiar with, in response to the children's mental health crisis, we have expanded our services to support emergency medicine physicians. So we do encourage you to give us a call for any assistance with pediatric patients in crisis. And then as a reminder, today is part 1 of the suicide prevention training. So Dr. Payne will be giving part 2 on June 16th as well. So without further ado, I will go ahead and introduce Dr. Payne. Dr. Robert Payne was born and raised in Baltimore. He received his BS in chemistry and psychology with honors in general education from Frostburg State University in 2005. Following graduation, he worked as a mental health worker on the children's inpatient unit at Shepherd Pratt, and he then completed his medical education at West Virginia School of Osteopathic Medicine in 2011, his adult psychiatry residency at the Charleston Area Medical Center, West Virginia University Charleston Division in 2014, and he completed his child psychiatry fellowship at the University of Maryland and Shepherd Pratt in 2016. So upon completion of his training, Dr. Payne stayed at the University of Maryland in Baltimore as an assistant professor in the Department of Psychiatry. He is the child psychiatrist for the UMMC Child Psychiatry Consult Liaison Service, and he provides telepsychiatry services for the Maryland Department of Juvenile Services and supervises trainees in the ADHD and mood disorders clinics. Some of Dr. Payne's areas of interest include developmental trauma, attachment disorders, complex psychopharmacology, psychodynamic psychotherapy, positive psychiatry, and mentalization-based psychotherapy. So without further ado, I will go ahead and pass it over to Dr. Payne. Thank you for joining us today.
Thank you so much for that very kind introduction, Chelsea. And I'm very pleased to be here today to discuss this very important topic. So the topic is Suicide Prevention Part 1, and this is the discussion about active suicidality and non-suicidal self-injury. So I do not have any potential conflicts of interest to disclose. I'm a faculty member at the University of Maryland School of Medicine. I receive some salary funding from the state of Maryland via the BHIPP grant, and I'm a member of the American Academy of Child and Adolescent Psychiatry. Learning objectives for today's talk include know how to differentiate suicidal behavior and non-suicidal self-injury in children and adolescents. Identify risk and protective factors for suicide in children and adolescents. And lastly, learn how to conduct a suicide assessment. I'd like to extend a special thanks to Dr. Hal Kronsberg of the BHIPP team, who created the majority of the slide content presented today. So defining non-suicidal self-injury, NSSI, as we will refer to it throughout this talk just for the sake of brevity, is the direct and deliberate self-inflicted damage of body tissue without suicidal intention or socially sanctioned purpose. So the DSM-5 TR was just published in March of this year, and I highlight this because in the previous edition, this was in like the back of the DSM condition for further study. It has now been moved up to the main part of the manual, and that is relevant because that is something you can actually code as the reason for the visit. So the reason for presentation today, and this is may be used for individuals who have engaged in intentional self-inflicted damage to their body or of a sort likely to induce bleeding, bruising, or pain. For example, cutting, burning, stabbing, hitting, excessive rubbing, in the absence of suicidal intent. And the different codes are for current non-suicidal self-injury, and that is if this NSSI behavior is part of the clinical presentation, and The second code is if it's occurred during a patient's lifetime but is not part of the current presentation. So we conceptualize self-harm as a behavior. And why do we see it that way? Self-harm is not necessarily a treatable disorder in and of itself, but it can signal the presence of other disorders. Something reinforces the self-harm to enable the behavior to persist. To stop the self-harm, you must address the antecedents and consequences. Self-harm is often the beginning of our investigation, whereas a diagnosis is typically like at the end of the investigation or at the end of the assessment, we make a diagnosis. So this is from a classic book, The Perspectives of Psychiatry, which formulated this triad of goal-directed behaviors. You have your antecedents with your predisposing and precipitating features, which lead to responses or the actual behavior of question or concern. There are choice and action features within that behavior. And then there's consequences with reinforcing and sustaining features. This is learning's path. Why do kids self-harm? So there are four main outcomes. How does self-harm work? There could be increase in desired feelings, including self-punishment, self-stimulation, endorphin release. There could be decreased undesired feelings, feeling less overwhelmed or sad or angry, reduce the feeling of emptiness. There could be increase in the desired social response to gain attention or support. Some caregivers or other, other people that might be involved might classify this as manipulative behavior, which we try to acknowledge that, but also, discuss how this could be a form of communication. So that's I think a more helpful way of thinking of it. And lastly, a decrease in undesired social response, i.e. to stop bullying or fighting. What kids reported in this study was 25% endorsed an increase. They self-harm in order to increase a desired feeling, 65% to decrease an unpleasant feeling, 35% to escape anxiety or feelings of overwhelm, 24% to escape sadness, 20% to escape anger, and 29% to escape a bad thought or bad memory. 4% of this data set to create a desired interpersonal outcome, 15% to decrease a negative interpersonal outcome. So is it non-suicidal self-injury or is it a suicide attempt? What's the difference? The key distinction between a suicide attempt and NSSI is the intent underlying the act. In NSSI, the person's intent is to feel better in some way. When I was creating these slides, I read somewhere NSSI is thought of as a morbid form of self-help, which I think is a very poignant way to look at it. The person wants to feel better in some way, whereas in a suicide attempt, the person has at least some intent to die, even if considerable ambivalence is present. Doing an assessment of NSSI, let's say they come into the emergency room. First, you want to do an exam, look at the site. Are there signs of infection? What is the person's tetanus vaccine status? They might need a tetanus shot or a booster. Lastly, whether a somatic treatment is necessary, or stitches needed, is wound dressing needed, things of that nature. Once the wound or the areas of injury are stabilized, then you can start focusing on taking the history of what happened. So the what of cutting, when did it start? And by the way, bold are the things you want to prioritize in a 15-minute visit, assuming, this assessment might be done in an urgent care setting or in the pediatric primary care office. These are things that you could prioritize during that time. So how do you self-harm? Cutting, burning, scratching, purging, using drugs. How many different ways? How often? Where do you do it, or where do you self-harm? With what? Ask to see scars. In my experience, when you ask to see, people are generally forthcoming because there's I think there's a desire to stop hiding, and there is some relief that comes from being validated that this is a concern that, and people are tired of, or kids are tired of hiding it from people, and trust the professional to show. So, and then ask who knows about it. How do those people feel about it? What do your parents know about your self-harm? The why of cutting. In general, how are you feeling before you cut? What does it do for you? Does it help you feel more or less of a particular emotion? How do other people react to your cutting? And how do you feel about that reaction? And how well does it work? I think this is a compassionate, non-judgmental approach to the questioning. Oftentimes kids are, you know, out of frustration, caregivers might, react in a punitive or shaming way, whereas we're coming from a position of non-judgmental concern. And I find that that's very refreshing to the kids that I've worked with. What next of cutting? Assess suicidality, because self-harm may not be a suicide attempt, but the person self-harming may still be suicidal. How much did you want to die when you hurt yourself? What did you want to happen when you hurt yourself? The relationship between NSSI and suicide. How worried should we be when you see a kid with this behavior? So self-harm and suicide are connected. Predictors of self-harm and suicide attempts include multiple methods of self-injury, hopelessness, parental conflict, and depressive symptoms. Depressive symptoms is bolded because they did a study, a large treatment study of British adolescents, and they basically showed that over here on the left-hand side of this bar graph indicated if there is a non-suicidal self-injury present in month pre-baseline, the percentage of kids, even after being treated for depression, remain with self-harm events, even after like about 6 months of depression treatment. 3 times risk of self-harming again, 2 times risk of suicide assessment. Even when depression is treated, self-harm can persist. It's thought of as a sticky behavior, again, because of those reinforcing and sustaining features. The kids continue to do it for those reasons. And when self-injury and depression co-occur, we really need to emphasize safety planning around suicidal thoughts and urges. Key take-home points for NSSI, including the what's. Cutting alone doesn't tell us everything about a diagnosis. Kids who cut rarely engage in more than 10 discrete episodes in their lives. Kids who self-harm struggle more with strong emotions. Kids who self-harm can have poor social judgment, and non-suicidal self-injury is strongly associated with future suicide attempts. Why? Most kids typically self-harm to make a feeling go away, and it's rarely for attention. What now? Assess suicidality, determine the function of the self-harm, and identify comorbidities. What next? Treatments work. We will talk about treatments in our next talk on June 16th. We're going to pivot to youth suicide, which is a public health crisis. In the United States, youth suicide is a growing public health problem that contributes to healthcare costs, lost productivity, morbidity, and premature death. Suicide is preventable, and we all have a role in its prevention. Some definitions of suicidal behavior. Suicidal behavior includes suicidal ideation, which is simply thinking about ending one's life, suicide attempt, non-fatal suicidal behavior, and suicide is ending one's life. Again, this is now in the DSM-5 TR as a reason for visit. So this category may be used for individuals who have engaged in potentially self-injurious behavior with at least some intent to die as a result of the act. Evidence of intent to end one's life can be explicit or inferred from the behavior or circumstances. The suicide attempt may or may not result in actual self-injury. If the individual is dissuaded by another person or changes his or her mind before initiating the behavior, this category does not apply. So if suicidal behavior is part of the initial encounter with the clinical presentation, for example, I work on the consult service here at the hospital. A lot of the patients I see have overdosed on an over-the-counter medication, Tylenol, for example. They need to be admitted for, acetaminophen toxicity. The suicidal behavior when the initial encounter in the ED can be this first code right here. And then subsequent days in the hospital while they're being stabilized, it can be the second code as part of subsequent encounters with the same clinical presentation. If they have a history of suicidal behavior, that's obviously relevant because, as we'll discuss, that's a very high, that's a strong risk factor for suicide, is a history of suicidal behavior. So this is a nice picture illustrating the spectrum of suicide risk, assessment intervention strategies for each level of risk. So all the way on the left, you have no suicidal ideation. You may have normal focus on end-of-life issues due to advanced age or severe medical illness. They may have occasional thoughts of their own mortality, but they do not feel that they would be better off dead. The intervention, periodic screening, patient-specific. Higher risk, passive suicidal ideation. They occasionally or intermittently have thoughts that life is not worth living or that they would be better off dead. For example, they say, I pray that God will take me soon. They have not thought about harming themselves, however. They require further evaluation. Higher level of risk, they have active suicidal ideation. They have thought about harming themselves. Example, I've thought about taking all my pills, but I would never do it. Again, some ambivalence present. They do not report specific detailed plan or current intention to harm themselves. They demonstrate reasons for living and good impulse control. They still require an immediate evaluation because they are thought to have active suicidal ideation. The highest level of risk, they have a specific detailed plan or current intent to harm themselves. For example, I'm planning to take all my pain medications tomorrow morning, or they do not have reasons for living or good impulse control. I may not be able to stop myself from doing this. This person needs an emergency immediate evaluation. And here in Maryland, we have a system where we can do an emergency petition, which is a totally different conversation, but that's a way we can facilitate how this person can be psychiatrically evaluated on an emergent basis at a local ER here in Maryland. So in the spirit of time and how much material we have to cover here, I just wanted this one epi slide to be in here. I think it's important because it's important to highlight, number one, suicide rates are much lower among kids in the age 10 to 14 age group. Typically prior to puberty, suicide was thought to be rare relatively compared to kids 15 to 21. However, from 1999 to 2017, suicide rates among that younger age group, 10 to 14, saw a much larger relative increase compared to older kids. I think that's important. Males are at higher risk for ending their lives by suicide than females. Suicide rates do vary significantly by race. For example, American Indian and Alaskan Natives are at highest risk for suicide by a factor of 2. So risk factors, this was a case control study of Medicaid data of youth 10 to 18 years of age. More mental health visits within 30 days of a crisis decreased odds of suicide. Suicide most highly associated with major depressive disorder, psychotic illness, substance use disorder, bipolar disorder, and seizure disorder. Some static risk factors. LGBTQ youth have more than 2 times the rate of suicidal ideation. A family history of suicide attempts. history of physical or sexual abuse, previous suicide attempt, and a history of non-suicidal self-injury. Some modifiable risk factors include firearms in the home, regardless of how they are stored. Pathological internet use, for example, visiting pro-suicide websites is thought to be a modifiable risk factor. Family conflict and academic stressors. So we can talk about some suicide screening tools as well as pros and cons. So the PHQ-9A, which is recommended by the guidelines for treatment of adolescent depression in primary care, they have suicide screening questions as listed below. In a large study in pediatric primary care use, 8.6% of kids were positive on the suicide screen, and half of those kids did not meet the threshold to screen positive for depression. So the ASQ is a brief suicide screening tool developed by NIMH. It's meant specifically for use in pediatric primary care. It is also validated in the emergency room and outpatient settings in large-scale studies. So we're going to spend a little bit of time talking about this tool because I think it's very helpful, very useful tool. It's in the public domain, and it's been adapted for an inpatient setting, outpatient setting, and emergency room. So you start off by asking the patient, in the past few weeks, have you wished you were dead? In the past few weeks, have you felt you or your family would be better off if you were dead? In the past week, have you had thoughts about killing yourself? Have you ever tried to kill yourself? If yes, how? And are you having thoughts of killing yourself right now? Again, that imminent suicide risk that places them, if they are having thoughts right now, then they need immediate psychiatric evaluation. So this is hard to see. I apologize for that. I will include this in the supplementary materials we provide with this talk. So this is a decision tree within the ASQ, which is a portion of a broader suicide assessment. Positive screens are meant to have a more comprehensive evaluation, including the brief suicide safety assessment. It's meant to help divide patients into 3 risk groups requiring different intensity of interventions. So those 3 risk groups right here are low risk, further evaluation needed, imminent risk. In the context of the emergency room, the difference between this imminent risk is that this is a stat consult to psychiatry, whereas further evaluation needed is more of like a routine consult or a routine evaluation. Either way, the person should have safety, they should have some safety measures put in place. So some pros and cons of these ASQ questions. So some pros would be, it takes very little time to administer. It's part of a larger toolkit that includes a clinical pathway flowchart and more comprehensive suicide assessment. It also has some script questions and some wording that has been developed as a more standardized tool. It has high sensitivity and high specificity. On the other hand, some drawbacks include very low positive predictive value. 30% of positive screens were actually true positives. Asking if kids have ever tried to kill themselves can be overly broad, and language used on the screener can be a little jarring to patients. So assessing suicide directly. It's helpful to start broad and open-ended. Over the last month, how have you been feeling about being alive? Follow-up questions gently move up to a higher level of acuity. Have you had moments when you wish you were dead? Did you ever reach a point when you thought about trying to end your life? Ask about frequency, intensity, and how do you manage those thoughts when they come? If there is a specific thought to commit suicide, follow up again with questions about the plan's details, including lethality, feasibility, and desire to act on it. You want to ask what's kept them from acting on this plan thus far. And don't forget to ask about home. To what extent can parents and caregivers supervise if needed? So at the end of your suicide assessment, you should know, Has your patient had thoughts of wanting to be dead? Has your patient had thoughts of committing suicide? How frequently and how intense are these thoughts? Does your patient have a plan for suicide? Specifically, what would your patient do? Does your patient have available the tools, objects to act on that plan? And what has kept your patient from acting on that plan? Lastly, do parents and caregivers have the ability to provide additional supervision if needed? Some techniques for eliciting sensitive information. We're going to talk about normalization, shame attenuation, gentle assumption, symptom amplification, denial of the specific, and behavioral incident. Normalization involves asking about suicidal ideation only after making clear that it's normal to think about suicide at one time or another, especially in painful or difficult circumstances. For example, you could say, many people with depression like yours can feel so bad that they think of suicide. Have you had suicidal thoughts? Shame attenuation involves people feeling ashamed of their suicidal thoughts or behaviors and blaming themselves. Again, symptom of depression is feelings of excessive guilt, and that might be, feeling guilty about having these thoughts and the impact it might have on their families. The technique of shame attenuation blames the person's pain, illness, or situation instead. You could say, with all the pain and hopelessness you feel, do you think of killing yourself? Gentle assumption. If someone feels any shame, embarrassment, or fear about disclosing suicidal ideation, then yes, no questions can deter the person from answering honestly and might give you a false negative. To avoid that problem, the technique of gentle assumption calls for you to act as if the person has already said yes. What are some ways you have thought of killing yourself? How many times in your life have you attempted suicide, if at all? This is similar to when we're taking a substance use history. We'll say, how much do you drink? You gently assume the person drinks alcohol, as opposed to saying, do you drink, yes or no? People are likely going to say no, even if they do. Symptom amplification. This involves assessing not only if the person is thinking of suicide, but also how often and how intensely. It calls for you to exaggerate the possibilities, which gives room for the person to answer honestly without necessarily feeling that they are thinking of suicide excessively. You could say, how many times a day do you think of suicide? 20, 30, to which the person responds, oh gosh, no, not that much, only 5 to 10 times, I'd say. Denial of the specific. Instead of asking a single overarching question that covers many possibilities, denial of the specific technique requires you to ask separately about each possibility. Ask separately about each specific possibility rather than stringing together multiple options in one question. With each of these possibilities, the professional waits for the person's response before moving on to the next possibility. You could say, have you ever thought of jumping off a high place, like a bridge or a building? Pause. Have you thought of taking an overdose? Pause. Hanging yourself, shooting yourself, cutting yourself. Behavioral incident. Ask questions about each step in the person's thoughts and behaviors in response to stress, pain, hopelessness, or other difficult emotions or situations that might trigger suicidal thoughts. By breaking the person's experience down into very concrete details, you help strip away any vagueness or distortions that might obscure the person's true experience. When you took out the bottle of pills, what happened next? What did you do next? Then what did you do? What were you feeling when you did that? This particular technique, I find, gives us very valuable data when we're doing a safety assessment, a suicide assessment, because you're able to get to the details of the attempt, what preceded it, what was going through their mind, what were they hoping, and these ways of asking questions, people are typically will give you a lot of helpful information so that you can know the appropriate intervention after that. So this is a resource for patients. This is new and upcoming. So it's a crisis hotline number. just like 911, it's 988. Patients experiencing a mental health crisis can call or text 988 and will be directed to the National Suicide Prevention Hotline. This is coming July 16th. And this is a link to the for more information. To be continued, please join us for Suicide Prevention Part 2, Safety and Crisis Planning on Thursday, June 16th. Thank you all for your attending this event presented by BHIPP. Here's our hotline. Follow us on the social media platforms. We have time for comments, discussion, questions.
Thank you, Dr. Payne. If folks have questions, feel free to go ahead and place those in the chat now, and we will read them out. So we do have one question. Dr. Payne, can you discuss differences on how you approach assessment with younger versus older children?
Absolutely. Sorry, I'm just switching off my slides right now. So yeah, well, first, the ASQ is validated down to age 8. So in the supplement of the ASQ that I was reading, they said that a child that's younger would need like a separate, basically this tool wouldn't really, wasn't developed for them. They still would obviously need like a psychiatric evaluation. With younger children, it's rare, but you can still have, children do experience suicidal ideation, and it's climbing in that age group. Oftentimes, developing rapport with playing a game or, some play therapy, we have in our outpatient center, we have like a dollhouse, and we have different games in the office, and we have, I have good old Uno right here, just like spending some time with them, gaining rapport, and eventually, getting to the suicidal questions. But with younger kids especially, it's important that you spend that time to get them to feel comfortable. My older kids, I tend to think of more like my adult patients, where you can be a lot more, like it's important to build rapport, but the interview technique is more similar to adults than it is for younger kids. So that could be anywhere from like 14 to 18.
Dr. Payne, another question. How do you handle it when parents minimize these reports or symptoms in kids and adolescents?
Yeah, great question. So I try to, so my own personal practice, I disclose that I have 2 children of my own, and that, we all want what's best for our children. And, sometimes before I had kids, I felt ill-equipped to address, and they would always call me out like, "Hey, doctor, do you have your own kids?" And I would say, "No, I don't." And they're like, "Well, you don't know what you're talking about." But now that I do, I feel like I have some credibility. And so we always say we want what's best for our kids. And this is obviously very troubling and upsetting to think that our child might have these thoughts of ending their life. It's a lot to face, and to just sort of acknowledge that it's something that would encourage denial, because it's so terrifying to the parents to think that their child would want to kill themselves. And it's just easier to simply deny that it's true. But so part of the ASQ that we discussed, it has a very deliberate pathway to actually interview the child by themselves. And in my experience, in child psychiatry, it's very routine that we always interview the children by themselves, because you want their history. They are the patient. After interviewing them by themselves, you interview the family or interview the caregiver in the presence of the child, or separately, whichever works better for you in that situation. By telling them that you spent the time and asked them the questions, and this is what they told you, and we have to take these things seriously. Simply telling them that children do kill themselves, and like this is the second leading cause of death in this age group. Like all those things, sometimes parent that will shave down their denial, but um, if it persists, then that's a different discussion. Maybe we can maybe we can talk about that more during our next talk.
Dr. Fien, another question. Can you provide any background to the process when a student is received from school during the school day? I have experience of sending children to the hospital after being assessed as high risk and then find out that the hospital didn't assess because the child said they were feeling okay.
Mm-hmm. All happens all the time, every day. Yeah, I would say in my experience, sending kids from my practice to our ER, and that still happens. Frankly, the way that I try to address that the best I can, and it's better now that we have a system called Tiger Connect, which is like a communication system that everyone in the access or the hospital is registered with, or at least everyone seeing patients. So when I send them to the ER for an evaluation, I want to talk to the person that is going to be seeing them, and I want to, relay my concerns, and I want to tell them like this is what was endorsed in the office, and that this is why I'm sending them, and I'm very concerned, and I think they should strongly consider, at least, you know, monitoring them for more than a day, if not hospitalizing this patient. And oftentimes that's been helpful, but I've also had my fair share of patients that were discharged because, they go and they deny everything. And um, at that point, I just have to be very careful and, continue to follow that child very closely. But, it's unfortunate, but you did your due diligence by sending them there for an evaluation. You tried to speak to the evaluator. If the child doesn't endorse suicidality at that time, their hands are tied. They have to discharge them, but that doesn't mean you stop your intervention. There's been studies that show just frequent brief phone check-ins can be very helpful at preventing suicide. Simply just calling and checking in on people like over a period of several days or a week can be very helpful.
Thank you. Okay, we have another question. What do you recommend that we do when the police refuse to take a child to the hospital that is suicidal? We have no crisis center here. The mobile crisis does their very best, but they're not always available.
Yeah, wow. I don't know, like write your congressman. Wow, what do you do with that? That's a tough one. I don't think I've ever had that experience here. And yeah, so sometimes, our clinicians will here at this hospital um will physically take the child to the ER if the child is like not actively aggressive and those types of things. That might be a situation where, like, for example, our clinicians here at our outpatient clinic will walk them to the ER. I know that's probably not the same as your situation, but um, doing our best to facilitate that child getting there one way or another. Sometimes we have to be creative in these situations that are challenging. I'm not sure if that answers your question. That's a very challenging situation you're in right there.
Looks like she just made a follow-up comment. We can't EP because we can't see them.
Mm-hmm. Yeah.
Okay. Next question we have is how long is long enough versus too long for suicide watch for a teen who has a history of cutting? I have a patient who still has the father sleep on her bedroom floor a year plus after cutting because she can't say that she wouldn't want to hurt herself again. So she won't contract for safety, it sounds like.
Mm. Yeah, so, well, that sounds like a very devoted father, first of all. Um, yeah, so, that sounds like a patient where, and I know DBT is difficult to access, but DBT programs and their access to like coaching calls is a helpful way, again, with the behavior finding a different way of doing a competing behavior. People might have heard of, you know, replacing the sensation of burning themselves or cutting themselves with like holding ice, for example. When they have these overwhelming feelings, to like identify someone they can reach out to, and also part of the safety plan, which we'll discuss during the next talk, would be, finding ways that they can soothe themselves, but to like really get to the bottom of what are the things that we're trying to self-soothe with cutting. And also, that sounds like a situation where I wonder what could be done to like intervene with that particular dynamic, because I think father's continued presence might be reinforcing, not saying she's doing it for attention, but this is like a way of securing her father's like affection and his like attention in a way. Um, and so like what does that look like when she's not like actively cutting, like what is his involvement, and how can we intervene like in a more family therapy kind of way? But there's multiple approaches to take to that. But again, another very difficult problem.
We have another question. What services like therapy and OT should we offer for kids remaining in the ED for weeks while awaiting inpatient psych care?
Yeah, so in our program here, we have exactly that. We have an occupational therapist who comes, and sees the child in the ER, and does some, and also we have psychology here at this hospital. On our consult service, we have patients awaiting beds just like we have in the ER. But it's super important um, that we wrap them with services the best we can. And sometimes, let's say we do the best we can to mimic the inpatient environment while they're boarding. They might not need an inpatient bed if they've actually improved with the services. Occupational therapy, we have child life here at this hospital. Psychiatry, possibly start a medication if they're depressed or anxious or whatever. And psychology services to really discuss like, what are the underlying difficulties leading to this either non-suicidal behavior or suicidal behavior. So we definitely have that model here at this hospital, and it's been very effective and very helpful.
And what recommendations do you have for children who have suicidal ideation and don't have close parental supervision?
Yeah, we see that a lot, don't we? Yeah, so unfortunately that does happen, and that's a situation where we have to like lower our threshold for, more acute care services. Here in Baltimore City, we have like the B-Cars system. But basically, and also we have a outpatient mobile crisis team, or mobile treatment team that I used to be a psychiatrist for, actually. And but basically these services are for patients that have possibly an inadequate level of supervision combined with a higher risk for unsafe behavior, suicide, cutting, those kinds of things. But basically it's like an effort to wrap them with services, and or like this patient might have the same presentation because they don't have adequate supervision outside the hospital. We have to admit them because that we can't develop an adequate safety plan to prevent them from harming themselves. So it really just kind of lowers our threshold for admission.
And a question, will the mobile clinic come to hospitals in Anne Arundel County for our ped psych patients?
Yeah, so that's a good question. I think every county, I'm not sure if every county, but I think lots of different counties have a mobile crisis team. I'm mostly, because I practice in Baltimore City, I'm aware of ours, but certainly give our BHIPP line a call, and they can help, you know, guide you through the referral process and how to engage in local crisis, mobile crisis services.
I'm going to go ahead and put a link in the chat for Anne Arundel County Crisis. Oh, someone beat me to it.
Nice.
Liz.
That's awesome.
Tony, yep. Okay, back to in-home supports, the in-home therapy or case management. Looks like she's saying for private, I cannot find any. Okay, that's a resource question. Any additional questions for Dr. Payne at this time? Please feel free to go ahead and put those in the chat. Okay, a question. We have patients who refuse life-saving medication, insulin for a patient with type 1 diabetes. One particular patient was in the hospital numerous times due to this, among having many other psychosocial issues, yet was not seen by psychiatry. What can be done to ensure that medical staff can view this kind of behavior as self-harm?
Yeah, I mean, it sounds like a patient I was seeing on the consult service. I wonder. Luckily, we were involved in that situation, but so yeah, that's a tough one. But so was it that I'll have to ask a couple of questions. So was it that the psychiatry service was refusing to see him or her because of like they didn't think it was like a psychiatric issue? Yeah, but I can say, for our patient, it was, they came in frequently for, diabetic ketoacidosis, and they were, not taking their regimen, and we found that it was simply a, the structure of taking medications, necessary medications at home, and mom was also taking care of like a autistic younger child and was very overburdened and didn't have a lot of support. So, the child was in a way parentified and was given a lot of latitude with their medications and, only at the age of like 13 or so. And the child obviously just wasn't doing a good job of managing her diabetes on her own because it's obviously very difficult. But um, it took a while for us to intervene meaningfully with that family, but it was really kind of helping mom understand, helping the kid understand that this is like, this is really, really important, and addressing the psychiatric comorbidity as well with some counseling. Um, but yeah, that was a really tough case, and that is a tough one to continue to see.
Okay, another question. Do you recommend any grounding strategies for suicidal teens?
I do, yeah. There's I think what I'm going to do is in the supplement is going to well, actually, again, this a lot of this is going to be like, come to our part 2 talk. Yes, there's some really great grounding strategies, and they are evidence-based and they do work.
Another question. It sometimes feels tricky to monitor when shifts happen from NSSI to suicidal ideation in ongoing treatment with teens. Other than ongoing regular assessment, do you have any other tips of things to look out for or ways to engage or gather new ever-changing information?
Yeah, that's a great question. So one thing that increases suicidal risk is multiple methods of injury. So one thing that makes NSSI a risk factor is that as they continue to self-injure, it continues to like desensitize them to more and more invasive, potentially lethal ways of harming themselves. So something you could objectively track is like, are they self-harming not only more frequently, but more severely by multiple methods, multiple areas? Is it escalating? Because would be a risk factor. That would be a sign that this is like they're becoming more and more high risk, as well as, you know, how are the other interventions going? How is like the treatment for depression and other comorbidities going? If you find that you continue to remain at like an impasse, or like you're just not making much progress, then you would be more, you know, more concerned, and this would be like a higher acuity case that you would need to, like, you know, just stay really on top of.
We'll give it just another minute to see if anyone has any additional questions. Just as another reminder, the part 2 to Dr. Payne's talk will be on June 16th. If you're participating today for a CME or a CEU credit, please be sure you take the survey. Rebecca has placed the link in the chat. We do appreciate all your feedback. And we, again, will just stay on for another minute in case anyone has any additional questions.
Well, I see one more in the chat box about if there's any data on the interface of NSSI and substance use abuse, and there is. So I will. So everyone gets access to these slides, right, Chelsea?
Yes, the slides will be sent out, and this will be posted on our website as well.
Awesome. Yeah, so that one of the papers, you know, that basically studied like what are the characteristics of kids that are at higher risk. Substance use was one of them, and it's considered a form of NSSI in and of itself. But I'll try to find some more information about that aside from the paper that was already referenced in the slide, and talk about that next time. But another good question.
All right, it looks like that might be it. So thank you again, Dr. Payne, for giving this presentation today, and thank you everyone for joining us. Have a great afternoon.
Thank you, everyone. Have a great day. See you June 16th.